get Ipi-Nivo, but in the study arm, patients are getting 12 weekly Nivo rather than having it all up front. So that's the difference between the two. And the primary endpoint was to see if there was less toxicity, and the secondary endpoints were around efficacy. It was presented by NAV 18 months ago at ESMO. We've got some further follow-up data from that, and then we've done some immunohistochemistry for PD-L1, FOXP3, CD8, which I'm going to share with you today. I'm also going to share with you the updated overall survival signal. The previous follow-up was only 12 months. It's now 3 years. The original survival signal was therefore incredibly immature. This is now a more mature survival signal. It's not the 5 years we've seen in 214. This is the primary endpoint. It's been presented before. It's positive. If you give intermittent 12 weekly Nivo, it's better tolerated, and I don't think that should come as a big surprise to anyone. If you look at the response rate, it doesn't seem to matter too much between the two approaches. And you can see here, actually, with response rates in the region of 40%, they're very much in line with 214. So I think this reinforces the 214 data, which is nice. Progression-free survival, again, of 11 months is in line with expectations. This is the OS data, which hasn't been seen before. And you can see from here, OS, as you would expect, for the two regimes, is very similar to each other, in my opinion. Clearly, it's not powered as a non-inferiority trial, so I wouldn't overinterpret that, but it's very hard to say these two regimes are very different. It does therefore question whether or not you need to give the EP up front, and maybe for those patients who are struggling a bit, it's safe to wait and then give another cycle of EP 12 weeks later. And I think that's the clinical summary of the trial. I also think that this curve reinforces some of the other findings we've seen with other Ipi-Nivo trials. So what we've done here is we have a biomarker population, which is 156 of the 200 patients we originally included in the study. Favorable, intermediate, and poor risk were all represented in this study, which I think is a positive component of the biomarker part. PD-L1, as you can see here, was defined as TC 1% 288. That's the definition used in the BMS Ipi-Nivo biomarker. CD8 10%, FOXP3 5%, and you can see here 40% PD-L1 positive, 60% CD8, and only 20% PD-1. The biomarker population, 10.9 months, exactly the same as the ITT population, so it doesn't appear to be a selected group of patients. And this is the first sort of slide that's relevant, I think. You can see here the IMDC good risk in blue, and intermediate and poor risk in orange. CD8 is obviously a T cell marker, or is a T cell. FOXP3 is Tregs. We discussed Tregs previously in that brilliant talk around the balance between PD-1 and Tregs. And you can see here, actually, in intermediate and poor risk disease, all of these immune-related biomarkers, whether they're immune checkpoints, PD-1, whether they're T cells, or indeed their Tregs, are all overexpressed in those intermediate and poor risk patients. And then if you can try and correlate those with response, you can see here that biomarker high, so high CD8, and indeed high FOXP3 both correlate with response, whereas PD-L1 for TC and PT-L1 for IC does not correlate with response. This is much more complicated than it sounds because this is only a single-arm trial, and we know that the patients who are PD-L1 overexpress are also those poor-risk patients. So we're mixing prognostic and predictive biomarkers. And that is actually one of the big shortcomings of biomarker research with single-arm trials, and indeed, my career has been stymied by that sort of work in bladder cancer with PD-L1. So let's be very cautious about prognostics and predictive biomarkers. The interesting issue is actually when you look, FOXP3 and CD4 correlate each other quite strongly. So when you get high expression of CD8, FOXP3 follows it. It doesn't necessarily go in other directions. We've looked at composite biomarkers by combining the two biomarkers together. And we haven't shown the same findings with PD-L1 and Treg. We haven't shown high PD-L1, low Treg associated with high response rates. we did actually show high CD8, low FOXP3 associated with an 82% response rate. But at this point, the numbers are getting very small, and that's exploratory analysis of exploratory analysis. And I'm very cautious about jumping to too many conclusions with that sort of analysis. So this is what we plan to do, and this is what I'm showing today. There is some provocative data using the combinations. The reason why I think we need to be cautious around the PD-L1 issue is I think a nicer and neater piece of work was the work that Bob Motzer presented in the 914 Ipi-Nivo versus placebo adjuvant trial. And in this, using the same biomarker at 1% with 288, they showed a proportion of patients doing better who were PD-L1 positive than those patients who were PD-L1 negative in that big negative adjuvant trial. And Axel Beck sitting here is one of the co-chief investigators of that, and he may want to comment. So I would take this PD-L1 data more seriously than our exploratory single-arm PD-L1 data at this point. Of course, we can look at progression-free survival and overall survival as well. In a single-arm trial, it's difficult and it's underpowered for this type of analysis, but it's very hard at this point to say that high PD-L1 expression is clearly associated with better outcomes compared to low expression. And indeed, you can see the curves are actually flipped around the other way for PFS. That's probably statistical noise, but remember PD-L1 high expression for TC, not IC, but for TC is associated with a poor outcome. And actually, when you look at the 214 data, Ipi-Nivo versus sunitinib, PD-L1 expression appears particularly discriminatory for sunitinib. So those patients who are PD-L1 negative tend to do well, and PD-L1 positive patients do really poorly with sunitinib. So the prognostic component of PD-L1 is important for VEGF targeted therapy. I've flicked a couple of slides. CD8, we were more hopeful around. We were expecting CD8 to be more predictive. We didn't show that. It was associated with a higher response rate, but it didn't translate to better overall survival. And I think that survival curve, although then again, the numbers are small, is pretty compelling to say there's no striking finding. And of course, we looked at PD-L1 IC expression. You'll be aware that the Atezolizumab program looks at IC, while the Nivolumab program looks at TC, and we showed little to get too excited about here either. So this is Bernadette's work, and these are her conclusions. I think the updated OS from PRISM is consistent with 214. I think we don't need to be too religious about Ipi-Nivo given every 3 weeks. It looks like we can extend it, and it can be associated with equally good outcomes in an underpowered efficacy trial. I think the IHC biomarkers, including immune checkpoint T cells and Tregs, are overexpressed in poorest disease. This is consistent with some of the previous work by the Genentech group and others showing that poorest disease is associated with higher immune infiltration, good risk disease associated with higher VEGF expression. CD8 expression may be associated with better response, but not better outcome, but be very cautious around predictive and prognostic factors in single-arm trials. FOXP3 tracks CD8. This is the case in other tumors. And I think the hypothesis that these go in different directions and are associated with great outcome is something we need to work on more. It doesn't appear to be the case in this tumor type, and certainly our work with RNA and immunohistochemistry in bladder cancer also suggests that's the case. We're now working on extreme responders, and we've just performed the RNA analysis. We'll be looking at angiogenesis. I'm really interested in angiogenesis associated response to Ipi-Nivo. Excited about the future. Many thanks for your attention. I'm lucky. Oh, thank you. I'm co-chairing this session as well, so that gives me the opportunity to introduce my great friend and colleague, Dave McDermott. Dave, at this point, he had shaved. He hasn't on this particular talk. Unusually, I look smarter than David, which is very unusual. Thank you very much.
I didn't know my appearance would be such a big focus of the intro. If I'd known that, I would have dressed differently, I guess. So it's great to see you all. I was asked to talk about the Motion 150 program and what we've learned from that as it relates to the future of kidney cancer. And I just want to say two things off the top. One, I think, to use a term Tom uses all the time, I think the work from the Motion 150 program is, in 151, is brilliant. And in some ways serves as the Rosetta Stone for much of what we've done since in biomarker development, but also in target discovery, which I think is just as important when we're talking about tissue-based work. And number two, I had almost nothing to do with this, as I will harp on, and Tom certainly had nothing to do with this. Or nothing, I should say nothing constructive to do with this. How about we just said? All right, so many of you, since the development of immune checkpoint blockade, many of you in this room have been focused on the tumor immunity cycle and, how do we do better? How do we enhance the immune response to the tumor? Early on, it was preclinical data for mouse studies suggesting that if you blocked VEGF, you could enhance the immune response to the tumor by improving immune cell infiltration, enhancing dendritic cell function. Other mechanisms were proposed, but this all needed to be tested in humans trials. So in the beginning of what became the Emotion program, there was actually essentially what I would call a mouse study that was done in humans within the phase 1 trial of atezolizumab. And some of the results are shown here, where patients pre-treatment were biopsied. They were then biopsied after bevacizumab was started, and then biopsied a third time after the combo was started. And patients who got the combo, 5 out of 6 of those, we saw increased infiltration, we thought, of CD8 positive T cells, which is just what we were looking for, ironically. And when patients only got atezo alone, in those 9 patients that got dual biopsies, we only saw 1 of 9 with CD8 positive T cells. So we thought this, in some ways, this could recapitulate what we were seeing in mice, and this was very exciting at the time and hopefully would lead to improved outcomes in the clinical setting. Following that, a phase 2 trial was proposed, and early on in that development, 2 women shown here, Preeti and Maruk, where's Maruk? She was right there a second ago. She didn't step out for this talk. Did she? Oh, she's here. Good. Oh, thanks. Phew. I thought she was going to be worried about what I was going to say and stepped out of the room. All right, so she did most of the work for this. And a couple of points to emphasize. Some of this has been talked about in Ari's great talk from earlier this morning. This is the Emotion 150 trial design. And to me, this shows the value of doing phase 2 studies before you do a phase 3. We learned a lot from this study, and also trying to do a well-designed, looking at component parts, within a phase 2 context. This was designed to be hypothesis generating for the phase 3, but it was the first trial in any cancer type to look at immune checkpoint blockade with atezo and targeted therapy anywhere. First randomized trial to do that. It was also the first randomized trial to explore the association between outcome and tumor microenvironment gene signatures, looking at both RNA and DNA with next generation sequencing. So these are the heat maps that Maruk and her team generated. And from these heat maps, we thought we were able to come up with different groups of tumors, some that were angiogenic driven high, some that were T effector high, and then within that T effector grouping, a subset that were T effector high, myeloid high, that might be, we thought, less sensitive to atezolizumab, and then T effector high, myeloid low that did just as well when, with the combination. But obviously that required a prospective confirmation. So that's what the group at Genentech did. They took these signatures and put them into the translational work of the Emotion 151 study, which was a simpler study, just a 2-arm trial. This trial met its primary endpoint, as you know, for PFS, but the overall survival results were disappointing, which limited atezo's direction in the front line for kidney cancer. But we still learned a tremendous amount about kidney cancer biology, which was sort of the main goal of the Genentech team, and how it might predict for outcome. And so once again, from what the signatures that were developed in 150 were put to use in a prospective way in a motion 151 with a pre-specified analysis that was focused on progression-free survival. We can have a conversation about what's the best endpoints for doing IO-based biomarker development, but that was the primary endpoint for this study. And several of the things we thought we learned in the phase 2 were supported, or you could say confirmed, but certainly consistent within the phase 3 trial, that angiogenesis high tumors were more likely to benefit from sunitinib. If you're angio low or T effector high, you are more likely to benefit from the combination. So those results were similar to what we saw in the phase 2 trial. But more importantly, Maruk and her team sort of turned it up a notch in this trial because they had more samples and more advanced technology. They were actually able to do an integrative multi-omics analysis. This was one of the first that was ever done in the IO space for any tumor type. And building on those signatures, combining RNA and DNA, coming up with 7 potential clusters of kidney cancer biology, and then trying to associate those 7 clusters with outcome. Ari has shown some of this data, so I won't focus on it too much, but then also getting a deep dive in the over 100 patients on this trial that had sarcomatoid kidney cancer, helping us understand why those patients might benefit from immune checkpoint blockade, going beyond PD-L1 expression, focusing on upregulation of immune and cell cycle genes, and also the impact of the angio signature in those. It seemed as if angio low tumors were more likely to benefit, immune high tumors less likely to benefit with angio low, more likely to benefit with immune high. Also looking at mutations associated with sarcomatoid. Other groups have sort of expanded on this work and giving us some clues about why those patients respond and what we might target for non-responders. This was another, to me, this is another very important slide from this talk, data presentation. This looks at the gene signatures across the clinical criteria that we use to make determinations in kidney cancer. If I can say one thing that you will leave this meeting with is we need to move away, in my opinion, from using clinical criteria to make treatment decisions, to design clinical trials, to predict outcome, because they just don't predict. And this is why, because there are patients with good risk tumors that are angio high that might benefit from just a VEGF TKI alone. But there's also IO responders in that group. And you see that here with their inflammatory high signatures, even in the favorable risk group. So let's, as a field, agree coming out of this meeting that we should move away from clinical biomarkers more towards tissue-based biomarkers. And then she put it all together, and this is a very impressive sort of summary slide, looking at RNA, looking at DNA, looking at sarcomatoid, PD-L1, into those 7 clusters, giving us some ways forward for both targeted therapy and immune therapy, but also potentially some new targets to hit for the patients who are not going to benefit from from these 2 main agents that we use for our patients. And leading to this publication in Cancer Cell, and then finally associating these signatures with outcome, both for both VEGF and the combination approaches, and others have built on this work, as Ari described, with other combinations. So lessons learned, I've talked about some of this. This integrative analysis was critical, was the beginning. Others have built on it. We learned about sarcomatoid. We know we need to, I think, in my opinion, we need to rely less on clinical classification based on this results. And we need to do some prospective validation, which others are starting to do, which is terrific. I would say, as far as other things we've learned from this work, we need to we need to do phase 2 trials. We need to design them well. We need to do, I think, better biopsies. One of the things we learned from this is that it's preferable to biopsy a MET versus the primary. That's actually the tissue that we're treating when we're treating patients with metastatic disease. There was a fair chunk of patients who had metastatic lesions biopsied, both in the phase 2 trial and the phase 3 trial. We weren't just relying on archived specimens. Also, so if you didn't have a recent biopsy, you had to get a new one. I think that's something we all should be doing. We should be looking at fresh tissue, and we should be looking at bigger pieces of tissue. So excisional biopsies, like our colleagues in lymphoma do, not needle biopsies. And until we start doing these things, until we start doing these things correctly, in my opinion, we're going to come up with disappointing results. We're much more likely to come up with positive results if we change how we're doing these things. Also, when we're just looking at pure IO regimens, looking at connecting our biomarkers to IO endpoints, I think will also be important. That's something that Mike and Sabina have shown with the HCRN trial. And sort of this publish or perish concept, which is if you're going to do the work and collect the tissue, you got to show us the results. So there's some industry colleagues and some investigators who have published their data and others that have not. We need to push people to publish the data that they have so that we can learn and so that we can make advances. And even though the results here with this combination were somewhat disappointing clinically, I think we still can move forward with predictive biomarkers in more pure populations. So for example, I think we still can come up with markers for pure IO regimens. We almost certainly can come up with predictors of response to HIF2 inhibitors, and we should try to do that. I would predict that's going to be the VHL PBRM mutated group, but let's do it, so we can move those agents closer to the front line. Just because we've had some disappointments doesn't mean we can't have future accomplishments. And finally, the last slide, we need more trials like this. And Laurence's Bionic trial, this is Brian's Optic trial, trying to prospectively validate some of these biomarkers. We need much larger trials like this. Thank you very much for your attention.
So we have our next speaker, Dr. Gupta from Bristol Myers Squibb, and he's going to talk about biomarkers for PD-1 based therapies in RCC.
Good morning, everyone. Welcome. And I'd like to take the opportunity to thank the organizing committee for giving us this opportunity. So I was tasked to discuss about the biomarkers in the PD-L1 therapies, and I decided I'm going to pick up on two extreme spectrums. One on the PD-L1 IHC, which is the tumor-based biomarker, which Dr. Powles already touched upon. So I'll go a little bit deep on that part, and something promising from the future. So I'm going to touch upon some novel soluble factor from the circulating domain. So blast from the past, Checkmate 214 study, and here we did look into the PD-L1 tumor cell staining, and as discussed earlier, here what did we see was that with the increased PD-L1 IHC staining, and the threshold here is more than 1%, and this is tumor cell staining, we saw an increased trend for OS. In the Nivo epic arm, but it was diagonally opposite in case of the sunitinib arm, where the PD-L1 high patients tend to do worse. If we moved on to Nivo Cabo, which is a recent presentation in ASCO, we did see that there is no difference between the PD-L1 high and low in the Nivo Cabo arm, but the sunitinib trends which were identified in Checkmate 214 were again confirmed that the patients with a higher PD-L1 IHC had a significant worse disease-free, progression-free survival. These trends were again confirmed in Javelin Renal 101, where again we didn't see with the with IOTKI, there was not much difference in the outcomes in the for the OS, but in case of the sunitinib, you again saw the same trend being confirmed that the patients with a higher PD-L1 expression tend to do worse. And if now moving from the metastatic, if we go to the adjuvant setting, the disease-free survival analysis based on the PD-L1 tumor cell expression in Checkmate 914, we clearly saw that the patients with a higher PD-L1 expression had a hazard ratio of 0.4, whereas the hazard ratio in the PD-L1 low group was around 1.14. Again, is the adjuvant setting more appropriate for such analysis? Because here you don't have that metastatic and the samples are being taken at nephrectomy, and then you get a more clean analysis done. And this trend was also repeated in other adjuvant studies, namely Checkmate 564, where you see that with the increased PD-L1 expression, and here is the combined positive scoring, you do see the hazard ratio improving as compared to the lower PD-L1 expression. And even if we take from the combined scoring to the tumor cells scoring, or in case of emotion 010, we look into the immune IC analysis, where the PD-L1 expression is less than 1%, 1 to 5%, or 5%. So there is a gradual improvement in the hazard ratio from 1.09 and going to 0.57 for the expression of 5% and above. So in terms of the PD-L1 IHC, I think it seemed like the PD-L1 expression is more pertinent in determining clinical outcomes in the adjuvant setting as compared to the metastatic setting. It can be biology, but it can be also the kind of samples we are using. And again, most of the all the adjuvant studies, what we saw was the all directed to the PD-1 or the PD-L1 monotherapies. Again, as Dr. Brown and Dr. Sabina showed that, what kind of, it's not just the PD-L1 expression, but it's the host of other markers, but host of other cells, which are key in determining what can be our outcomes. So I think those need to be factored in. And the other is, inherent challenges associated with the tumor-based biomarkers, that is, its invasiveness, lack of availability of a longitudinal sample, lack of contemporary samples, which make it a little bit more challenging than investigating the circulating biomarkers. So I'll shift the focus on the circulating biomarkers that also offer additional opportunities for the precision medicine approaches. So I'm going to focus on extracellular matrix. And why extracellular matrix? Because the fibrotic changes across solid tumors, which are mostly driven by cancer-associated fibroblasts, etc., are well documented in like colon cancer, esophageal cancer, and also in PDAC. And these extracellular matrix alteration lead to desmoplasia, that is a strong core formation around the tumor cells, which may impede the filtration of the T cells to the main tumor, leading to immune suppression, and thus ultimately lead into the tumor progression. So on the right side, you see a forest plot of the hazard ratio across the various solid tumor types, like breast cancer, malignant melanoma, and liver cancer with PRO-C3. PRO-C3 is a collagen 3 formation fragment. And these analyses were done at the baseline. And what you see is a 2 to 3 time increase in the death rates in the patients with a high level of PRO-C3. So there are a bunch of these ECM markers available. And we applied these ECM markers in clear cell RCC in Checkmate 214 study. And these are serum-based markers. And here we had 3 broad categories: collagen formation, that is like PRO-C3, PRO-C4, and so on; degradation, collagen 3 degraded by MMP; similarly, collagen 4, collagen 6, or the inflammation-associated markers like TGF-beta LAP, although TGF-beta has a short half-life, but this is latency-associated protein, which kind of half-life is much longer than the TGF-beta. So what we observed were all these markers were highly elevated. As you see on the graph on the right-hand side, the gray bars represent the healthy volunteers, and the yellow, teal, and the red one shows the fold increase in these ECM markers across in the RCC. And here we have patients around from 600 to 900. So the data set is very strong, and we presented that in the SITC last year. So additional interesting part was that all these ECM markers, except PRO-C23, were associated with the IMDC risk criteria. And 9 of these markers, a mix of formation, degradation, and inflammation-associated marker, was significantly high in sarcomatoid patients. And the sarcomatoid patients have known to have an evolved collagen matrix, and they have a higher collagen 6 and collagen 5 as noted in the histological sections. We also looked into the predictive ECM markers, which was analyzed through Cox proportional hazard model. So we took these markers as a continuous variable. And in this analysis, what you see on the right-hand side, the dotted line represent the adjusted p-value of 0.4 adjusted for the FTRs. And the blue represent the PFS, and so the brown represent PFS, the blue dots represent OS. And as you see, the prognostic component, which is shown by the association in at least one of the arms, most of the markers were either prognostic, both for the PFS and OS. However, when we come to the predictive aspect of it, it's the brown ones, which are the PFS. You see around 9 markers which were predictive of Nivo-Ipi response. And none of these biomarkers were associated with the OS with Nivo and Ipi. Interestingly, in June, end of this June, FDA issued a letter of support for PRO-C3, and they issued this with regard to its utility as a prognostic marker for the risk of outcomes in the clinical trials in patients with a solid tumor. So it's a pan-tumor approval, or the letter of support which was given. I do acknowledge this letter of support is just a first baby step. There is you can see the series of things which it takes from early evidence to letter of support to the qualification. It has to reach that particular goal. But the good part is FDA kind of recommends its utility for example, for the stratification, and it also encourages us to investigate various cohorts with the patient with the solid tumor types treated with different type of treatment, including immunotherapy. So it's a pan-tumor marker, non-invasive, readily available, and FDA has recognized its prognostic potential. We have some more interesting data. We are framing up a nice manuscript about the on-treatment analysis and the predictiveness of these biomarkers along with the biology. Stay tuned for that. But I think, yeah, in RCC also, these PRO-C3 and other ECM markers have shown it's not only prognostic, but predictive potential. We are trying to assess those in upcoming studies like 9ER. So in terms of the future direction, I think we have learned a lot from the tumor biopsies. So I think it's time also to explore the liquid biopsies, the circulating biomarkers more extensively. And I think it's appropriately said that a couple of speakers who are going to speak more about ctDNA today, and Dr. Shu will also discuss about the KIM1, again, soluble biomarkers. So I think these are a little bit underutilized in RCC, and we should explore these soluble biomarkers also. I'm not saying they're going to be a single stop solution. We do require integration. We do require clinical labs. We do require AI. So it's not hand waving, but I think what we have seen in RCC as compared to other solid tumor, we require a little bit more heavy lifting here in order to deliver certain precision medicine approaches, as our first line setting is extremely crowded and there are fantastic therapies, but can we find those fantastic therapy the right home for the patients? With that, I'll leave. Thank you.
Thank you very much. Magdi and I agreed that I would introduce people who had heavy beards to the stage. So under those circumstances, I'd like to welcome my friend and colleague Axel Bex, who's going to talk about neoadjuvant trial design. Best of luck, Axel.
Thanks a lot. Thanks a lot. Also for the invitation here today. For me, it's always an honor to be here. And the talk I should give is on design of perioperative trials. Perioperative is a big field. So I'm not talking about adjuvant studies in the phase 3 realm. I think this is for pharmaceutical companies to do. For me, it's more about the neoadjuvant setting, as was already mentioned. These are my disclosures. I would say, so what is important when we consider perioperative trials? I think I have some experience, 2 decades now with having done these studies. For me, it's a given that biomarkers should be part of it. So I'm not talking about how to organize these biomarkers around it. They should be done at baseline. You should collect everything that is available. But I think it's important to design them properly, because what you don't want is that you're halfway through this trial and you realize it's not working. So how do you do your risk assessment? The length of pre-treatment is currently unknown. What is your postoperative adjuvant treatment if you want to do a perioperative design? We should also talk briefly about treatment-related side effects, especially on surgery, but also surgical safety and medical safety. And I think the primary endpoint is very, very important. And I would like to spend some time on that, because it informs your sample size and eventually gives you information about the feasibility. And I think especially most of these trials are now single-arm phase 2. So they should be vehicles for your biomarker program. So what you get in the end is a bunch of patients that you have included, and you will get results from the primary endpoint. And then you can look at discretions like response or no response or downsizing. And this gives you a start. That's what others have done in melanoma. That's what others have done in colorectal surgery. And I always like to go to ASCO and look at other tumor types. And this year there was a very interesting session about neoadjuvant therapy. And I can tell you that others in other solid tumor types are far ahead. They're already randomizing their patients. They have biomarker-driven studies where they select them previously. So we're very far from that. Let's go into the talk. We have experience with NeoAVAX. That's a 40-patient single-arm phase 2 trial that used a Simon two-stage design, where we pre-treated patients for 3 months with axitinib and avelumab. It had a sort of escape lane after 6 weeks. But what I want to show is that what you can't do in adjuvant trials, where you have the Leibovitz score or your TNM. By the way, TNM has an area under the curve compared to Leibovitz of 0.56. It's like flipping the coin, if you want to make a risk assessment here. But clinical TNM and biopsy-proven grade can inform you about the aggressiveness of tumors. And this was a study that we were able to complete. I've presented this at ASCO. We are currently doing the translational research program on this. And it is very, very important, as I already said, that you have an idea at the outset, that you do your tissue collection at baseline, that you do PBMC collection, plasma collection, fresh tissue. It has to be frozen in a certain way if you want to do a single cell T-cell receptor sequencing. These are things I learned the hard way after we've collected this. So all this needs to be designed before you actually start. Safety and adverse events, these are results from NeoAVAX. We also have them from other trials. But what is important is that it has also been in the literature on retrospective data after Nivo, that some have described this surgery to be very, very difficult, like post-chemo seminoma, RPLNDs. What we did find is basically patients who would present with bulky lymph node disease would have very strong inflammatory responses. I do think that there is something to say about this clinical condition, but by and large, most of these patients were actually fairly easy to operate on, like we are used to. We had one patient who had a delay of surgery for 3 weeks due to hypothyroidism. And this is something, I think, which brings us to the medical toxicity. This needs to be well managed. You can see here, we had a very good team. And we had frequent treatment interruptions, dose escalations, but also dose reductions and discontinuations. And I mind you, this is not little, because if we look at the PROSPER data that had been presented at ESMO last year, you could already see in the recurrence-free survival curves that were presented that 11% of the patients that were randomized to the nivolumab pre-treatment arm hadn't had an nephrectomy. And that is quite peculiar in a setting where you have high-risk disease and they should be all surgical candidates. So that's something to keep in mind, that it is very, very important not to have two toxic components in these neoadjuvant studies. Primary tumor response. We as surgeons always love tumor downsizing. It's very easy. You have RECIST 1.1, you apply it, the tumor diameter is very easy to measure. The question is that the most important endpoint? As I said, urologists love it because it may put them into the position to do a partial nephrectomy. It's clinically applicable. You can see here that 3 months of pre-treatment is probably not even enough to downsize these tumors. And we do know from work, I think, Laurence, you did this, from the trials here from Javelin 101, and Checkmate 914, that the median time to best tumor response of these big primary tumors is very often 4.5 months. But in a neoadjuvant setting, this is already quite long, and ethically, this might be quite complex. But what you can see is that the downsizing may allow you to discriminate. Here, the primary endpoint was the amount of patients who achieved a partial tumor response by RECIST, and then you can do your biomarker program on that. What I think is much more important, and I actually got stimulated by this from our melanoma group at the NKI, they used the International Neoadjuvant Melanoma Consortium to describe pathological response in the tumor bed. I admit completely, we don't have any data whether we should do this in renal cell carcinoma, but it is already done in other solid tumor types using this classification. And what I found interesting to see is that the downsizing of your primary tumor had nothing to do with the pathological response as it was described by the pathologists. And you can see that about 3 patients with 7.5 statistics of nothing had a near pathological complete response. These are the green lines there. But also some tumors that downsized dramatically had still more than 50% of vital tumor. And the way that is being done, and I think it's very, very important, maybe we should even have a sort of consensus in the field, because more and more are designing these trials. How do we want to define pathological response? The way we do that at the NKI is by approximation. These tumors are sliced in 4 to 5 millimeter sections. We are then looking at the macroscopic slides, identifying the tumors. They are blocked in whole mount sections. And then the surface is being stained by HE, read in a digitalized system, which is a slide score, then lineated, and then by approximation, they can give you the amount of necrosis. I think if we don't use these standards, then I don't know what, for example, the MSKCC is using at the pathological response and how that's being measured. And I think that's very, very important to keep in mind. Now, moving forward, I think it's important to move into randomization. This is an example of a platform trial we have at the NKI. There's another one at Cambridge that's run by Ren Stewart, but this is from my colleague, John Hanen. We are with the pathological response as primary endpoint. We are looking at 3 different arms. Each arm is a Simon 2-stage design of 23 patients at Nivo mono, Ipi-Nivo, and Nivo relatlimab. And you can see the biomarker program attached to here, PBMCs, plasma, fresh frozen, the whole micmac that you would usually do with all the beautiful things we heard here today. And I can tell you that we had, for example, one patient in the Nivo mono arm who developed an acute kidney injury, and his surgery needed to be postponed for a couple of months. We had one patient who was on Ipi-Nivo, 6 weeks only, so the treatment is 6 weeks, with a near pathological complete response. So you get, with these trials, you get a lot of information, and eventually one arm will be decided on once we have 14 patients per arm based on these pathological responses. And I think that is something that is a very beautiful model to decide about combinations that might be useful in this setting. This is my final slide. I think we should also move. It's a bit provocative. I don't want to say we have to do it this way, but this is a bit inspired by what my colleagues are doing at the NKI in melanoma, Christian Blank, for example, with the Prado trial. I think, first of all, we have to move away from these single-arm trials. We have to take neoadjuvant therapy out of the realm of where it sits currently and randomize it against the perceived current standard. I don't think that anyone has an appetite currently to do a phase 3 study after the results that came in, but we can have very beautiful other endpoints, like, for example, de-escalation of adjuvant therapy based on pathological response after you hit the tumor hard with, in my point of view, the best combination we have, Ipi-Nivo. We've done quite a lot of surgeries in patients who had their primary in place. Most of them were treated with Ipi-Nivo. We have a series at the NKR of 20 nephrectomies in patients who had complete responses at metastatic sites. 5 of them had complete responses, no pathological vital tumor data in there. So I think these might be options for the future, and we should just be a bit more intelligent here. So I thank you for your information, for your attention, and looking forward to the discussion. Thank you.
Thanks, Axel. Next speaker is Dr. Bakker from Harvard Medical School. And he's going to talk about development and clinical application of ctDNA in RCC.
All right. Well, Well, thanks very much for the invitation to speak today. Let's see if I can get this. There we go. Excellent. All right. Sorry. Right, I'm going to talk about roles of ctDNA and RCC. And, just to start out with, so here are my disclosures. ctDNA, I think, has generated a lot of excitement initially and actually some real clinical utility in other diseases than RCC in particular. And, why might ctDNA be a nice biomarker in RCC? Well, in general in cancer, it's, as has been alluded to earlier, a nice accessible way of looking at features of cancer without requiring tissue, potentially enabling larger scale and dynamic sampling over time. And I think there's a lot of reasons why, it could be advantageous to look at. And I'll talk about some of the challenges of that in RCC in particular. So as you probably know, as tumor cells die, they spill their nuclear contents into the circulation. And oftentimes we can pick up circulating tumor DNA and do sequencing to look for somatic mutations that can tell us something about prognostication or potentially provide predictive information to guide treatment. And to put this in a little historical perspective, this field has been, active for a long time. It actually dates back to 1948 when the first report of cell-free DNA in plasma came out. And I would say over the last couple of decades, there's been a lot of excitement about what this field could do for cancer care. A lot of it has been more kind of preclinical and theoretical. But to point out a few sort of milestones here, in 1994, there was the first description of a somatic mutation detected from cell-free DNA and RAS. And then 2014 was the first large-scale clinical validation of ctDNA analysis. And things have really accelerated in the last couple of years. And I put this slide here just to give a sense of how this is being commercialized and also brought to patients. So this is just showing, since about 2016, the number of FDA approvals and breakthrough device designations that have arisen. And this spans from cancer detection to also treatment selection and minimal residual disease monitoring. And this slide is probably up to date or out of date already, since this is a very active space. And at the same time, though, this, I think, value hasn't really translated to RCC yet. And there's a couple of reasons why. One of the main challenges applying this to RCC is sensitivity. RCC is often thought of as a low shedding tumor, meaning it probably doesn't sort of cell for cell release as much ctDNA into the circulation as other cancer types. And so on the left is the experience from Guardant, where they show that the median circulating tumor DNA content in a patient with RCC is around 0.5%, making it somewhat difficult to detect somatic mutations, although there's a large range. And then the experience from Grails on the right, this was admittedly enriched for mostly stage 1 RCCs, which are going to be a harder target to detect, but they found that only 18% of patients had detectable signatures of RCC in plasma. And I think a second major challenge has also been brought up earlier. I think these data were actually shown earlier, that there's not sort of the EGFR targetable mutation like in lung cancer that we can go after in RCC. This is the experience from Sloan Kettering looking at 753 RCC cases. The vast majority of these were level 3 in terms of actionability, investigational, and there's really only level 2 variants in MET, in papillary RCC. I think importantly, they did find that there were 4% of these cases that had MMR deficiency, potentially indicating a heightened response to immunotherapy. But it's certainly, RCC is a little distinctive in I think the lack of immediately predictive mutations. So my lab's interested in looking not just at genetic features of circulating tumor DNA, but epigenetic features as well. And I think there's some reasons why recent technologic advances in circulating tumor DNA profile may really unlock some interesting new applications here, particularly along the epigenomics path. So now we can look at some features in circulating tumor DNA that were difficult to detect earlier. DNA methylation is one, histone modifications are another that are really kind of the newest development. And then also people are looking at signals of nucleosome positioning. All of these really provide information about gene regulation. And so to show some data that came out a little while ago, this was a study led by Pierre Nuzzo and Jacob Burchuk. And they showed using this immunoprecipitation-based assay for profiling DNA methylation that they could identify these signatures of RCC based on DNA methylation of circulating tumor DNA and use that to distinguish RCC cases from healthy volunteers with high accuracy. And interestingly, the ROC curve on the right is showing that this approach, works to some degree in urine as well. You can also pick up tumor DNA in urine and identify methylation fingerprints that are characteristic of RCC. And so, how might this be used clinically? I think, one potential way is to sort of, guide adjuvant treatment of RCC. As we've talked about, KEYNOTE-564, adjuvant pembro improves CFS in intermediate high-risk patients after RCC. There's an analogous trial in bladder cancer that, Dr. Powles nicely showed by using ctDNA analysis. And I think this is a little bit more developed in bladder cancer. You can identify that the patients who really benefit from adjuvant immunotherapy are the ones who are ctDNA positive after surgery, basically, sort of giving you a readout of minimal residual disease that might be addressed with adjuvant treatment. And so I think the other way, aside from just potentially enhancing sensitivity of detection by providing more features to distinguish tumor DNA from healthy DNA, I think epigenomic analysis of circulating tumor DNA could also be very helpful for characterization of disease. And here's what I mean by that. So this is an ongoing study in collaboration with Dr. Schwery and Matt Friedman at Dana-Farber, where we're now looking at histone modifications in circulating nucleosomes that are released from cancer cells. And what's very interesting about this is that histone modifications really give a very detailed annotation of gene regulation. So they can tell you, the promoters of genes that are active and being transcribed. They can tell you what enhancers are turned on and regulating gene expression programs. And so this technology that's been developed recently called cell-free ChIP-seq allows us to do this on a genome-wide scale and look at a number of different histone modifications that each kind of tell us something about gene regulation. And so it's very early days for this work, but here's an example of how this could be useful in RCC, although there are many steps, I think, to complete here. This is looking at basically how cell-free ChIP-seq could provide an activity readout of some therapeutic targets in RCC. And I've chosen to focus on HIF-2 alpha because as a transcription factor, it's a nice one for using this particular flavor of the assay that can look at the activity of regulatory elements that are bound by transcription factors. So the schematic on the left is basically showing DNA where HIF-2 alpha is absent. And then when HIF-2 alpha binds, it leads to recruitment of some enzymes that add this specific histone modification to nearby nucleosomes called H3K27 acetyl. And we can measure that in plasma. We can map it back to the reference genome to know, that it was present at these sites where HIF-2 alpha is bound. And in a couple of samples that we've run, we can see signals that in RCC plasma, there's higher levels of this mark of active enhancers at HIF-2 alpha binding sites, potentially indicating that that's because HIF-2 alpha is bound there and, turning on enhancers and regulating gene expression. And, those samples are quantitatively, distinguishable from healthy plasma samples. And, I think the next step here is seeing, could this provide a quantitative readout of HIF-2 alpha activity that might be useful as a predictive biomarker for belzutafans and other sort of HIF-2 alpha targeting agents that come after that. But I think this paradigm is also broader than that. We can look at the promoter activity of basically any gene in the genome, which corresponds fairly well to RNA transcription. And so what excites me about that is I think any of the biomarkers that have been mentioned today that are based on protein expression or transcription, theoretically, we may be able to detect a correlate of those biomarkers in plasma by looking at, these histone modifications that correlate with gene expression. So in conclusion, ctDNA analysis is really increasingly part of clinical oncology, although I think it's yet to make as big of a splash as it could in RCC. The sensitivity and actionability of mutations in ctDNA have posed a challenge for RCC. But I think that epigenetic assays may enhance sensitivity and also provide, maybe even more interestingly, phenotypic readouts that can give us kind of a sense of predictive biomarkers that may be useful in clinic. And with that, I'll end and again, thank the organizers and thank the many collaborators and members of my lab who have contributed to this work. Thanks for your attention.
Going to invite Alexander Gusev to come and talk to us now about the correlation between the biomarkers associated with immune-related toxicity and immune checkpoint inhibition. Welcome.
All right, let's see if I can get this to work too. Great. All right, thank you again to the organizers. Thanks for putting together a really exciting session. I'm a statistical geneticist, and maybe you can tell, and I'm going to be talking about germline genetics, which is a little bit out of left field, but I hope to motivate the focus and sort of think and discuss this work. So thinking about the motivation of looking at germline genetics for associations to immunotherapy toxicities, I think this audience understands and appreciates the study of toxicities, but I also think that germline genetics offers something particularly unique for understanding mechanism. And specifically, there's a really wonderful review from Dr. Kalin a few years back in Nature Reviews Cancer, talking about the sort of challenges and pitfalls of biomarker discovery. And one of the points that's made really well in that review is that when we look at biomarkers, a single survival curve may have multiple causal interpretations. So if we see a biomarker that's associated with improved survival, that may be due to a direct causal effect on the growth of the tumor, or it may be indirectly capturing or sort of tagging some other components within the tumor that are also correlated with aggressive growth. And if we're thinking about interventions, it's really only that first scenario at the top where this association is relevant for an intervention. In the other scenarios, you can see that intervening on HIF, for example, would not have an effect on aggressive growth. So being able to distinguish these causal from non-causal mechanisms is really critical for moving biomarkers into interventions. And just to sort of go through this very briefly, one of the advantages of germline genetics is that it is fixed at birth, or at conception rather. And so an individual who has a polymorphism at birth has the same polymorphism at tumorigenesis, at the time of diagnosis, and at the time of treatment. And so when we see an association between germline genetics and something like aggressive growth, there may be other mediators along that arrow between genetics and outcome, but we know for sure that there is not a reverse causal association between growth and genetics because that genotype has been there the whole time. And so this provides us with, I think, a very useful causal instrument and an alternative to a lot of other biomarker approaches. The sort of fundamental question is, do we actually see these kinds of associations? It's great if we find them, but how often do we find them? And so we put together a large genome-wide association study focusing on immunotherapy toxicities using a mixture of real-world data from patients at Dana-Farber, as well as clinical trial data from a variety of collaborators. The data set breakdown and sort of the challenge, one of the challenges with looking at germline genetics is sample size is really key. These studies need to be done in thousands of individuals. And so we collected together with the Schwery lab data from around 3,000 patients on immune checkpoint inhibitors treated at Dana-Farber, annotated their charts for medium to high grade adverse events. And then we also inferred common germline variation from these individuals actually off of the tumor sequencing data, which I'll sort of save maybe for the end if there's time. We also worked with collaborators at MGH to put together a replication cohort, as well as a collaboration with Roche, Genentech for clinical trial data. And so with these three cohorts in hand, we conduct an association study. Again, this is statistically very straightforward. We're basically looking at whether each polymorphism in the genome is at an elevated rate in cases, the individuals who develop the toxicities, versus the controls. In practice, it's a little bit more complicated because we have to deal with the longitudinal timing of these events and loss to follow-up and so on. So we actually run this as a survival model, and we model the competing risk of mortality in these individuals. But at the end of the day, this is what we're looking for, an elevated allele frequency in one population versus another. And when we put all of this together, each of these dots here in the figure is a given test along the x-axis are the chromosomes, and on the y is the statistical significance. We find indeed 3 statistically significant independent associations with grade 2 or higher adverse events in this cohort. And I'm going to zoom in specifically on that association with IL-7, which is the one that we've sort of investigated the most and has, I think, a fairly clear now causal mechanism. So looking at that association in detail, again, because sample size is king, we had to start with a pan-cancer analysis, but we see, interestingly, a hazardous or toxicity increasing effect of this variant across a large number of cancers, individually nominally significant in a number of cancers, including in particular, interestingly, the largest effect in RCC with a hazard ratio of about 5. So sort of per unit of time, carriers of this allele are 5 times more likely to develop a toxicity. And even within that cancer type, this is quite significant. We, as I mentioned, worked with partners to replicate the association, and we see a significant and consistent effect in both the MGH real-world data and in the clinical trial data from a variety of trials done at Roche. And in that study, 50% of the carriers developed a toxicity within the first 200 days. We've continued to replicate this. So this is a cohort of melanomas from the Fairfax group in the UK. And now this is sort of a single cancer type. We see the effect even more strongly with an odds ratio of 6. Again, 50% of the carriers of this polymorphism, which is itself a 7% polymorphism, go on to develop some kind of a toxicity that requires immunosuppression. And in ongoing work, we are also seeing this very large effect size start to replicate in the Checkmate 025 trial, collaboration with Sorab, and in new data collected from patients at Dana-Farber since this initial study was published. So we're quite confident that the polymorphism has an effect in a variety of different contexts and a very large effect in the setting of RCC. A logical question is it's probably not just the SNP alone that has this effect, but there is an underlying causal gene. And one thing that's really nice with this genetic data is that we can integrate it with a lot of public studies of molecular variation. So here we're bringing the SNP over to a study of RNA-seq across a large number of individuals and looking at the key association. You can see that in non-carriers of this polymorphism, there's sort of generic activity of the IL-7 gene nearby. But as we bring in the carriers, both in the heterozygotes in blue and especially in the homozygotes in yellow, you see an activation of a novel cryptic exon in the carriers of this individual. And that exon is actually almost perfectly correlated with the polymorphism. And this is, again, something that we've replicated in the UK cohort, and we think is very strong evidence that IL-7 and specifically this sort of novel splicing in IL-7 is the gene mediator for this association. A logical question to ask when we're thinking about toxicities is, what about response? The other side of the coin, especially for medium or low-grade toxicities, which are often associated with improved outcomes. For this polymorphism, we don't see any association with improved response or decreased progression in any of the clinical studies that we've looked at. So this appears to be, so far, and here statistical power is a consideration, a polymorphism that substantially increases your rate of toxicities without giving you any additional clinical benefit in terms of anti-cancer treatment. And so I sort of alluded to a bit of a bigger picture in the final minute, and also the fact that this data was actually collected was germline genetic variation that has been inferred from sequenced tumors of these patients. And we have a separate paper showing that, in fact, for common germline polymorphisms, we can essentially impute that variation from any kind of molecular sequencing, RNA-seq, whole exome, targeted panels of tumors. And so this is something that we've been continuing to do for patients with targeted panel sequencing at Dana-Farber. As I mentioned, we're introducing more results from the now 4,000 patients on immune checkpoint inhibitors. But more broadly, there's a lot of panel sequencing going on at other institutions that haven't incorporated this study design. And so, for example, over 100,000 tumors in AACR Genie, obviously millions of tumors in the commercial setting. All of these are an opportunity to go back to that data, infer germline variation, and then conduct these kinds of association studies. So with that, I'll just rush through the conclusions. We found evidence of a germline variant, a common germline variant that's very strongly associated with immunotherapy toxicities, particularly in kidney cancer. We see that the effect is quite broad, and it's started to implicate interesting biology, both related to toxicity and in other work related to response. We're thinking very hard about what organ-specific effects this polymorphism may have and better characterization on the phenotypic side. We're also thinking about implications in the adjuvant setting, where I think managing toxicities is maybe particularly important. And then, of course, over the long term, whether we can actually start drugging or intervening on this mechanism. And with that, I just want to thank all of the folks involved, particularly the Schwery, Friedman, and Fairfax labs, and thank you.
Thanks, Alex, for that wonderful talk. A reminder to everybody, please use the social media hashtag KCRS23 to promote the talks. So far, Tony is doing an amazing job. I cannot keep up with him. I don't know how he multitasks. You know, it's very difficult. Our next speaker is Dr. Vincent Zhu. He's from Dana-Farber. He's going to tell us about kidney injury molecule 1 and use of this as a biomarker in RCC. Please, the floor is yours.
Thank you, Dr. Mollapour, for the introduction. And thank you for the conference organizers for this opportunity to share some of the data on KIM1 and kidney cancer. I have no disclosures relevant to this talk. So as has been alluded by multiple prior presenters today already, there's an unmet need for minimally invasive biomarkers in kidney cancer. And the analogy to other diseases like prostate cancer, where we have serum PSA as an easily accessible, easy to measure, and widely available biomarker, in kidney cancer, if we had this type of minimally invasive biomarker, it would change clinical care in many settings. It could allow us to assess on a population level which patients are at higher risk for kidney cancer. For patients with a renal mass, where we don't know if the mass is benign and malignant, it could help us to risk stratify which patients are likely to have malignant disease. And it could identify among patients with a tumor, which patients need to be prioritized for surgery versus active surveillance. A minimally invasive biomarker could help identify which patients after nephrectomy for high-risk kidney cancer may be higher risk and benefit more from adjuvant therapy. And finally, in patients with metastatic disease, a biomarker is needed that could help us identify which patients may be early responders to treatment versus which patients are at higher risk for non-response and may need to switch therapy early to avoid unnecessary toxicity exposure from ineffective therapy. And as I hope to show, plasma KIM1 is a biomarker that we've evaluated in each of these settings with varying degrees of data. KIM1 is also known as TIM1 and has actually been alluded to in several prior talks today already. The gene for KIM1 is HAVCR1 due to its role also as a hepatitis A viral receptor. This is a transmembrane protein, which for the purposes of this talk is highly expressed in injured kidney epithelium, especially proximal tubular cells, and is therefore highly expressed in all malignancies that derive from the proximal tubular epithelium, especially clear cell and papillary kidney cancers. Under normal kidney hypoxic conditions, KIM1 in the cell membrane acts as a phosphatidylserine receptor and detects exposed plasma membrane and leads to engulfment of damaged kidney epithelial cells. KIM1 is not expressed under normoxia conditions in healthy kidney, and in kidney cancer specifically has an ectodomain that is cleaved by metalloproteinases and is circulating in the peripheral blood. And it turns out that this ectodomain of KIM1 is detectable by a variety of methods. In prior studies, most investigators have used either mass spectrometry or sandwich immunoassays to detect this ectodomain of KIM1. And we have developed a custom MSD-based sandwich immunoassay, which can be done reliably using only 25 microliters of plasma, so very, very small plasma samples at a cost of only $10 to $15 per sample. So a relatively easily scalable assay. We've also shown for this assay that KIM1 is stable under storage conditions as well as multiple freeze-thaw cycles, making this appealing as a relatively accessible biomarker. we found that plasma KIM-1, I should say in work that was previously led by Dr. Ghislaine Silo, as well as my mentor Rupal Bhatt, these investigators found that plasma KIM-1 is elevated in banked plasma from a large prospective primary care cohort up to 5 years prior to the diagnosis of RCC, showing that plasma KIM-1 appears to be released even in pre-diagnostic occult tumors. More recently, we have shown in multiple cohorts that pre-nephrectomy plasma KIM-1 can distinguish patients with benign masses from those with malignant masses versus healthy volunteers. And we looked at this in 3 cohorts. First, in a Dana-Farber cohort, which included patients with RCC of all stages compared to healthy volunteers, plasma KIM-1 was able to distinguish these 2 groups with a high degree of discrimination, AUC-ROC of 0.93. Next, we looked at 2 different cohorts of patients with predominantly renal masses, excluding patients with metastatic disease. As you might expect, the performance is a little bit weaker in patients who do not have widely metastatic disease, but encouragingly, KIM-1 had signal in all cohorts we evaluated. Particularly interestingly, we were able to see a signal for KIM-1 detection of renal malignancies even among patients with very, very tiny renal masses. And this was shown in the Johns Hopkins Biobank cohort, where patients had all CT1A renal masses. Most of these renal masses were 2 to 3 centimeters. And we found that plasma KIM-1 was higher in patients with malignancy versus benign masses, such as cysts and angiomyolipomas. Next, we asked the question of whether KIM-1 in this pre-nephrectomy cohort not only can identify which patients have cancer, but may also identify which patients have higher risk cancer and need to be prioritized for surgery versus surveillance. And again, we looked at 3 different cohorts internationally. And among patients at the Dana-Farber Cancer Institute, as well as from the Blochen Cancer Institute in Moscow and the University of Würzburg, in all 3 cohorts with patients who had renal masses in place and were found to have kidney cancer, successive increases in quartile of plasma KIM-1 were associated with worse progression-free survival, higher risk of metastasis, as well as worse overall survival from kidney cancer. Taken together, these results suggest that plasma KIM-1 may be a useful biomarker for identifying which patients can be safely surveilled versus which patients may have progressive malignancy from their renal mass. Next, we asked the question of whether plasma KIM-1 may predict recurrence and survival in the adjuvant setting. This was data that was done as a post hoc analysis of the ASSURE randomized trial in kidney cancer. We analyzed 418 patients who had high-risk kidney cancer post-nephrectomy, and we found that successive higher quartiles of KIM-1 were associated with worse disease-free survival and worse overall survival. And this remains significant after adjustment for other comorbidities and pathologic stage, histology, and tumor size. Next, we also looked at plasma KIM-1 in the metastatic setting, and this was a collaboration with Maruk Husseini and colleagues at Genentech, where we analyzed plasma at baseline from patients who were randomized on the IMMotion 150 trial, of which you heard about earlier today. And indeed, we find that patients with higher quartiles of KIM-1 also had worse overall survival in this trial, with the caveat being relatively small numbers. In ongoing work, we're very interested in seeing if plasma KIM-1 collected serially in patients with metastatic disease may indicate which patients are responding to treatment and which patients are not, even earlier than we can detect changes on scans. And so we obtained plasma from Checkmate 009, which is a phase 1b study of nivolumab in patients with advanced or metastatic RCC. Plasma was collected at baseline and also at just 21 days after the first dose of nivolumab. And we tracked changes in KIM-1 in correlation with clinical outcomes. And we will have more data to share about this trial tomorrow. In summary, we've established that plasma KIM-1 is a prognostic biomarker in kidney cancer that seems to track with tumor burden. What we want to know is whether plasma KIM-1 can be a useful biomarker clinically, which will require prospective validation in other clinical settings and studies that show that this actually can help us to make decisions in kidney cancer. For example, we're starting to investigate whether plasma KIM-1 can provide orthogonal data that combines with other biomarkers to improve sensitivity and specificity compared to any biomarker alone. Part of that is working with companies such as Telix to image patients with novel biomarkers, for example, shown here, girentuximab PET, and to show whether KIM-1 can correlate with these findings. Several other presenters have discussed other biomarkers, including ctDNA, for example, which we're also interested in combining with KIM-1. Second, we're investigating whether plasma KIM-1 in the adjuvant setting can have signal in more modern adjuvant trials. And we're managing plasma from several of the modern immunotherapy trials in the adjuvant setting to see if plasma KIM-1 can identify a subgroup of patients with high degree of benefit from adjuvant immunotherapy. And third, the question from the therapeutic standpoint is whether KIM-1 has a biologically targetable mechanism. And indeed, with collaborators from the Bonventry lab, which helped to characterize KIM-1 in the original studies of kidney injury, we're working on identifying the biologic pathways that regulate KIM-1 and the sequelae of inhibiting KIM-1 in kidney cancer to see whether this may be a targetable pathway. And with that, I would like to thank my many mentors and collaborators, of which most are actually in this room, including Dr. Shueri at Dana-Farber, Dr. Friedman, Dr. Signoretti at Brigham and Women's Hospital, as well as Dr. McDermott at Beth Israel, our many statistical collaborators. And additionally, all the various collaborators in the United States and internationally, which have helped us to gain access to these plasma samples without which any of this work could be done. I'd also like to thank my funders, including the CDMRP and the Kidney Cancer Academy through the DoD, as well as the Concord Cancer Foundation and the Dana-Farber Kidney Spore. Thanks for your attention.
I'm going to invite Adam El Naga to the stage, please. From Natera, he's going to talk about treatment monitoring with ctDNA, really exciting area across a broad field of cancers. We're not doing much yet in kidney cancer, but I hope that's going to change very soon.
All right, well, thank you for having me come speak. I do realize I'm the last one, so I need to keep you engaged through this. So we'll start with a Johnny Carson reference. So if you've ever seen the show, one of his skits is Karnak the Magnificent, where he'd be handed an envelope with a question that no one's seen. Hold it to his head and use his mystical powers to come up with the answer, and then open the envelope and see what the question. Of course, the joke was how the two matched up. And that's kind of what we've been doing with renal cell cancer. When anybody asks what's the detection in it, depending on the study, it's 17%, it's 50%, it's 100%. But what is baseline? Is it prior to their surgery? Is it after their surgery? Is it upfront advanced, or are they recurrent? Are they on treatment, or are they not on treatment? What's the assay being used? So in a study that only went down to a depth of about 10,000 and tracked only von Hippel-Lindau variants, it was in the 10% range. When you start going down to 200,000 depth and start tracking 250 genes, now all of a sudden it starts to jump up into the 50 and 60 range. And so there's a big issue with what we're driving. We're not looking for an answer to a question. We're just throwing out the test at renal and seeing what happens. Now, there is some issues with it. So that's not the only problem. So we know that ctDNA is a poor prognostic marker. So not surprisingly, ctDNA detection in renal cell carcinoma is more common if it's a large tumor or a more aggressive tumor. And so that shouldn't come as any surprise because they're at higher risk at baseline. But one thing is this question about the shed rate, which doesn't really make sense because the kidney is heavily vascularized. And it does seem that they have low levels of mean tumor molecules, or in this case, the VAPs would be like sub 1% for that. And it does seem to be that there's a difference between the histologies that are there. In another study by Barata et al. That was looking at IO monitoring, similarly, it was also low MTMs, but also when he applied the IMDC criteria, if you had a good prognosis, nobody had it. If you had a poor prognosis, everybody had it. And then if you were intermediate, it was kind of a mix in there. I turn it off. There it goes. All right, so then one of the other ideas is about the tumor heterogeneity within renal cell. So the idea that you need to present larger tissue or higher tumor purity in order to adequately make the assay. There's also the clonal evolution that can occur within renal cell. So in one study where they looked at tissue and plasma at the same time point, they saw 77% concordance to what they were getting NGS of the plasma and NGS of the tumor. But then when you space those out in another study where you went out 22 months, suddenly the concordance is 8.6%. And then if they shrunk it down to 6 months, similarly, that concordance went up. And then same thing when in another study that looked at, by Powell et al. That looked at 13 patients with sequential time points, they saw that the concordance with the tissue decreased as time from that one was there. And so that brings that is an example of that clonal evolution, which we'll go back to. And so one study that looked at a baseline preoperative ctDNA, again, one of the limitations of this one was it was stage 1 through 4. And so the ctDNA detection there was only about 50%. Another limitation of it was the fact that it was intentionally looking at, we'll take a cohort of people that didn't recur, and we'll take a cohort of patients that did recur. Well, as you can imagine, you can't make a better prognostic marker than whether you recurred or not. Nothing's more prognostic than you did recur. So that's a limitation of it. But of the patients that were ctDNA positives, 72% occurred at a median time frame of 16.2 months. And then if you were negative, only a third recurred at a median of 31 months, which was statistically significant. Similarly, that was 50% there. If we look at a different study, now it jumps up to 81%. So this was by Jonas et al. And in it, patients with metastatic disease with plans for a cytoreductive nephrectomy, baseline detection was 81%. So who are you looking at? And what we did see was that same prognostic factor there. So if you were negative and stayed negative or positive and cleared just 6 weeks into that neoadjuvant sunitinib, no recurrences occurred. And then if we looked at it by just change, not necessarily clearance, you could see that the responders that had a greater than 50% response did not progress, whereas the ones that maybe did have a grease, but not as significant, there were the recurrences. And of course, if it rose, all those patients to eventually recur too. And so there's a question about where the baseline is and who we're testing it on. If we look at longitudinal monitoring, this was that study by Barata et al. They looked at 20 patients that were on an ICI regimen, whether in combination or a monotherapy, that had already been on therapy for at least 12 weeks and showing some signs of benefit. And so the median time to that first test was 4.3 months. And so we're looking at patients that have already been on the therapy, and we found a baseline detection rate of 50%. Then if we looked at that concordance of ctDNA with the clinical outcome, that's where we saw a concordance of 83%. So 15 out of 18 patients, if ctDNA rose, that did correlate with progression. The 3 patients that were missed were patients with isolated brain mets, and then also one who lacked their protocol time point. And so brain mets also is one of those questions, are we able to detect that? Some studies that have said they've detected brain mets with time have also presented with liver mets, peritoneal mets, some other mets going on. So then there's a question of, was it the brain that was detected or the other micro mets that are going on? But in this, both of them were missed. but all 10 patients that had a rejective response all either remained negative or became negative. In another longitudinal study monitoring, this one was purely RCC, we saw that if you were ctDNA positive, that correlated in 20 of 22 patients. So 91% concordance with radiographic findings. Similarly, if you were ctDNA negative, that was a 92% concordance with radiographic response. And so the one patient that was not ctDNA negative, their ctDNA did go down as the patient has a partial response and remained at stable disease from there. And so when we start to look at the surveillance study, this was going back to that Bosch study, looking at his biobank. So there were 15 patients that were pre-op negative and then after surgery stayed negative. And of that group, 3 events occurred, but only one of them had a plasma sample collected within 6 months. And then among the patients that were positive, 6 of the 13 had a time point prior to recurrence. So this has led to this perception that the sensitivity of ctDNA is only around 43, 47%. But in reality, if you just had 2 patients with a pre-recurrence positive, that sensitivity would jump up to 60 and so on. So the majority of recurrences did not have a pre-recurrence time point. And so I think to summarize everything, I'll just go back to a reference from Doc Brown to Jennifer and back to the Future 3. It's just that all this information together, I think just means that the future hasn't been written yet. We need to ask the question first and then look for the answer, or find the clinical scenario where we think ctDNA may be helpful and then look at those patients rather than just bucket renal cell NOS.
Imagine, should we do this? Adam, should we just start with, before we move on, should we just, while you're here, should we start with ctDNA? Is that fair?
Sure, thank you. You should have brought one up.
It's okay, you get a full service.
For the moderator, for the online folks, the questions will come through here.
Beautiful. We'll read those questions. I'm going to be in charge of reading, if that's okay with you, Magdi.
Yes, absolutely. We are running 10 minutes late, by the way.
We'll go quick. We'll go quick. So let's just start with ctDNA and let's cover that because there was 2 presentations on ctDNA. My first question is, you've actually showed data in advanced disease using an informed approach with 70% of patients being ctDNA positive. That's, I guess, is higher because most people feel that renal cancer is not a ctDNA shedder. Is that pivotal and changing, or is that just exactly what you expected?
That tumor informed
70% of patients are positive or detectable.
In the metastatic
Yes,
one.
in
Yeah,
LHD.
no, that would be what I would expect because we know that higher risk disease, higher grade, larger tumor burden are going to correlate with higher levels of ctDNA. And so in that study, using the tumor informed approach, was able to detect them at such a high level.
And what next study would you do with an unlimited budget and to show that ctDNA has an important role in RCC? What's the study that you would do if you were able to do anything you wanted to prove that ctDNA is relevant? And do you, my second question is, do you currently have the right test, or do you need to wait longer to improve the accuracy of your test? So is your test fit for purpose, or does more work required?
I think there may be some more work that needs to be done before it's ready for the pivotal integral biomarker study, because there hasn't been a standardization of the assay and there hasn't been a standardization of the patient populations there. So if I were to ask a question to get an answer, I could see where there's been some studies that in the adjuvant setting, treatment has not shown a benefit. And so similar to like an InVigor type idea is, are we able to identify the patients where the event's going to recur? And so what is the baseline detection after surgery to help inform that?
And I don't know if Sylvan is still in the audience, but what's your take? And perhaps you'd like to answer that with this ball or come up to the, if you want to come up to the stage for us, that'd be super cool. What's the advantage and disadvantage of the methylation approach that you described over the informed approach that Adam described?
Yeah, no, I think that people are increasingly looking at basically all of the analytes that can distinguish circulating tumor DNA from healthy DNA, because challenge at all the space is really detection limits. And so I think there's a general trend to look at, genome-wide somatic mutations in some approaches where they're sequencing the entire tumor, looking for thousands of even non-coding variants that you wouldn't catch with targeted sequencing, trying to track those, and also DNA methylation. And some of these other things like, histone modifications, I think will help push the detection limits further. And then beyond that, there's glycosaminoglycans and lots of other analytes as well. So I think, particularly if in the place where, like you said, clinically we want to apply this, the limits of detection remain challenging. I think some of that may be overcome by, just enhancing, expanding the number of analytes we're looking at.
Questions? So what we're going to do is a question we'll do ctDNA to start with, and then what we're going to do is get the RNA folks up here. So let's get through the ctDNA initially if we can. There's a question there, far away, sir.
Hi, Sylvan. So a question about the choice of what histone modification to even go after, right? K27 acetylation probably will pick up because of open chromatin being chewed up easier than other regions, but I think also is one of the least abundant in terms of picking up, I guess, stoichiometrically. So one question is technically, is there a better alternative that we should be chasing? And in line with that, transcription factors are promiscuous, right? The same motif could be recognized by a HIF, but also 10 other things. Are you trying to couple what you're reading out as a potential HIF responsive element, coupling that to, let's say, belzutifan sensitive versus insensitive patients? What are the changes that are occurring over time? Could that be the biomarker for detection?
Yeah, absolutely. I think the first question just regarding which histone modifications one to go after, like I mentioned, it's early days with this, so we're still kind of exploring, and there does seem to be some amount of variability of, which ones are, easily or not easily detectable, probably for technical and pre-analytical reasons that we're still characterizing. But there are hundreds of these histone modifications, many correlated with each other, but each one telling you something different about sort of the local epigenetic state and typically gene regulation. So that's an area that we're definitely exploring still, and there may be more tractable marks in the long run. The second question, yeah, so I think that's a good point. One of the things that we'd like to do early on is be able to basically benchmark what we're reading out in terms of HIF2 alpha activity inference to what's actually happening in a tumor, where we can look at downstream genes and sort of be sure that this is actually a functional readout. And so that work is yet to be done. I think what I showed was a step one of a very much multi-step process, but I think that's the kind of thing that we'll need.
Do we have another question for the ctDNA group, or can we move on to the R? Oh, we have a question far away. Last question for ctDNA folks.
Just one question. Well, first, that joke you can't do without Ed McMahon next door to him. But anyways, I think the ultimate study in terms of looking at whether ctDNA can really pick up the heterogeneity is some of the studies that Charlie Swanton did early on, New England Journal and others, and now others have done. Have these people also looked at peripheral ctDNA and seen if they can pick up DNA from the various sites of the metastases?
I'm not quite sure about their specific group doing that, but we referenced that there was this clonality question and the concordance that was there with the tissue. But then we also looked at the treatment monitoring question, and those were patients that were on IO therapy in the recurrent setting for years, and the assay was based on their original tumor biopsy. So I think it also comes down to the assay question and how it's being done.
So to ask that question,
in order
maybe
to follow it.
to ask that question maybe a different way, if renal cancer has more tumor heterogeneity than other tumor types, does that make an informed approach somewhat redundant? I've asked a good question. That's very unusual.
I don't know that it does make it redundant, because oftentimes if you're doing the tumor naive, you're looking for a specific mutation. So you're asking the tumor, do you have the things I'm looking for? And as we move forward with more and more targeted therapies and more escape mechanisms, and as you mentioned, the idea of what's happening over time, I think they become susceptible to treatment pressure, where those sort of things may be lost And so if you're looking for a specific thing and that heterogeneity is there, you may end up missing it.
Magdi's going to lead the next section.
No, it's okay. You can do that. I just had a quick question. So you were talking about DNA methylation. There are some mutations. I mean, it goes back to Ari's talk at the beginning. You know, he was saying, oh, there are no mutations, but you tend to see CDKN2A mutation, but also there are some mutations like PRMT5 that impacts DNA methylation. So have you considered that, looking at those type of mutation, maybe rare, but nevertheless that impacts?
Yeah, that's interesting. So, you know, mutations that basically could have a correlate kind of in the epigenome that you could read out. That isn't something we've looked at yet, but I think is an interesting idea. And yeah, I think, you know, certainly, you know, there are lots of mutations. I think that the challenge is still kind of in the sort of what you do with it. But I think that, you know, particularly sort of enhanced sensitivity and some of the things we're talking about, I think could unlock that.
We got 7 minutes, carry on.
So what I'm going to do now is I'm going to ask David to come to the stage, and I'm going to ask we're going to ask Vincent to come to the stage as well, and also Surab, please, the three of you, and then perhaps Magdi, you could lead the questioning. But you around this is the RNA part of the talk. So questions from the audience on. We've got a question already on those three presentations, and we've got 6 minutes.
This is a very quick question to Vincent. Did you have a chance to look at the carbohydrate part of KIM1, whether that's altered or not, or that's just the same as normally?
That is a great question and a great thought. We have not looked at carbohydrate part of KIM1.
But you're planning to?
Tell me more.
I mean, there are, in other cancer types, there is some evidence that actually might be altered carbohydrates. Those are the tumor-associated carbohydrates that drive immune checkpoint response inhibitor, immune inhibitor response. So it might be worth looking at it, whether in this case, in kidney cancer as well, it's not only neoantigens, but for example, altered carbohydrates that might lead to response to treatment in terms of antigen-mediated cytotoxicity or things like that.
Okay, it's a great question. I have to say that maybe we should talk afterwards, because I'm not aware about the specific carbohydrate component of KIM1, which, as you know, is a transmembrane protein, but may be associated with certain carbohydrates.
Questions from the audience. Before we have a question for the audience, I've got a question for David, if I may. In fact, the whole three of you. One of the problems of the trials we're doing at the moment is we're using biomarkers predominantly for trials, both of which have got VEGF targeted therapy in them. 214 is the main exception to that, but it's usually sunitinib, which is a VEGF targeted therapy, with another VEGF targeted therapy plus a PD-1 inhibitor. How can we genuinely identify predictive biomarkers when there's VEGF in both arms?
So I alluded to this towards the end of my talk. I don't think you can. And I think we've proven that over and over again. So I think you can develop biomarkers for pure VEGF therapies. I think in some ways we've learned more about predicting for VEGF than we have for IO in the trials we've done so far. People have cared less about that work because the assumption was that pure VEGF would disappear as a therapy. I think those assumptions were incorrect. VEGF is going to be hard to kill in kidney cancer, and figuring out which patients could benefit from it more in the front line is still a reasonable thing to do. But pure regimens, pure IO, we can certainly come up with predictors. For HIF blockade, we almost certainly can, because that's tumor targeted and much more fixed than these dynamic markers we're looking at that are not in the tumor, they're in the tumor microenvironment. We've sort of tried to develop markers in potentially the most difficult way possible, and one of the most difficult tumors possible, with small samples that were old. You know, we couldn't have designed it better to fail than we did. So but we're going to learn, and we're going to do better, I think.
Thank you, David. Question from the audience. Yes, hands far away.
Yeah, I have a question for Dr. Gupta. I was interested in some of the data that you showed around the pro-collagen, pro-peptides that are circulating. I thought it was very interesting because, let's say, in some of the xenograft models, for example, tumors that implant very nicely tend to have a stromal signature, meaning they're able to interact with the tumor microenvironment, etc. What is your thought where this may go? And it wasn't clear to me exactly, maybe I just didn't fully understand. Do you think this marker could potentially predict, let's say, recurrence, meaning the ability to interact with stroma and implantation, if you will, in the adjuvant setting, or let's say it could be a marker for more sensitivity or resistance to VEGF inhibitors, or purely immunotherapy by building this barrier to immune cells? Where do you think this would fit in, and where are you going to take it, so to say?
Thanks for the question. There are multiple parts of it. So because of the time constraint, I didn't show, but these markers do connect well with the tumor burden. The high ECM markers, they do connect with the tumor burden. In terms of their correlationship, at least in the PDAC, we have demonstrated that if you have a core, which is the desmoplasia is very clear in the PDAC settings. There you can see clearly that, the T cells don't infiltrate inside the tumor. So that's that. In RCC, we are still working on that, but it's not, the collagens are not just the fragments which are inert, but they also have a significant signaling capacity. For example, Pro-C6, it is as pro-fibrotic, as inflammatory as TGF-beta alone. So there are multiple dimensions which is being attacked from, and these markers in other autoimmune disease settings, etc., are being used for clinical decision making. So they have seen the regulatory path. So what I'm trying to tell you, this can be attacked from multiple fronts, and at least on treatment samples and the predictiveness of these biomarkers is promising. And let's see the data sets coming from 9ER, etc. Would we be able to confirm these and build upon those?
Tony's got a question at the front. I've got a brief question, and Maggie's going to wrap it up.
Problems, and that's why I liked what Axel said, is that we tend to be super focused. GU, kidney, non-clear cell. This is the one, and we don't go and visit. So I may have missed the FDA. It was an announcement. It was kind of like, about that prognostic marker in oncology. If you can expand on it, is it a prognostic marker in a setting of metastatic disease? What's the relationship with IO, kidney cancer, and your passion, the ECM biomarkers?
Let's keep my passion out, but let's focus on
well.
So in terms of its prognostic capacity in pan tumor, this is across those metastatic setting, across the solid tumor, where the data set that was coming from 1,692 subjects, where it clearly showed across the tumor indications that higher the level, the worse is the prognosis in patients with the solid tumor. And their RCC hasn't been added up. So RCC was followed up later, and it again dovetails to the same thing. So within BMS now, we are doing a pan tumor analysis in terms of the prognostic capacity of these markers.
Going to the FDA, or it was an investigator sponsored biomarker
so it was
project?
Led by Nordic Bioscience, the company who does that, but the data is coming from 3 different publications coming from around more than 1,700 subjects.
And what's the drugs that cannot target that poor prognostic pathway? Sorry.
So it's mostly it's IO therapies and also the TKIs, but because it's the prognostic part.
Okay.
So there hasn't been any data submitted related to the predictive component.
Okay. Thank you.
That we'll be doing. Yeah.
We've got a question at the back.
Excellent work, and amazing to see sort of KIM-1 pan out in so many different disease settings. But think about moving maybe from biomarker to actually therapeutic target. I guess the question is, where is it coming from and how to target it? You focus a lot on the kidney tumor cells. I guess there's some recent work about this being a new inhibitory checkpoint for B cells. So is there any sense in kidney cancer, where it's coming from, how to target it, and what role it plays biologically?
Yeah, thanks, David. That's a great question. So there is some data on this, and I didn't have time to get into it a lot during my talk. But when you look at gene expression levels in human tissue, KIM-1 is upregulated in, as I mentioned, hypoxic kidney. It's also expressed in certain T and B cells. And there was a recent paper about 3 weeks ago in Nature showing that KIM-1 or TIM-1, which is another name for it, is a marker of bad actors in B cells in kidney cancer. And so there's some indication that, for example, B cells that overexpress TIM1 are associated with worse prognosis in kidney cancer and could be a therapeutic target. There is some interest in targeting KIM1 therapeutically. For example, there was a phase 1 trial looking at an antibody drug conjugate, actually led by Dr. McGregor, who's here, and Tony Schreiber is also part of that, of course, which was a cytotoxic antibody-drug conjugate against KIM1. That phase 1 trial showed some clinical activity, but was limited by toxicity. And I think part of the issue is that because it's a kidney injury molecule, if you're targeting KIM1 specifically, if the patient happens to have hypoxic kidney injury, you end up killing the kidney, and that leads to bad things. And so I think we need to be a little bit smarter maybe about how to target KIM1 in a more biologically kind of driven way. And for example, maybe not just killing every cell that expresses KIM1, but rather in targeting the biology of KIM1 and seeing, KIM1 appears to be part of the kidney's native hypoxia response pathway. And does inhibition of KIM1 actually affect the kidney cell function? And I didn't get into this too much, but KIM1 actually is a palmitic acid receptor and leads to uptake of palmitic acid into the cytoplasm. And this contributes to the lipid overload phenotype of kidney cancer. And we're working on preclinical experiments, so it's a little bit too early to say, but there are small molecule inhibitors of this, and it'll be interesting to see what they do in kidney cancer.
Maggie, do you want to wrap this up?